Ms. Ejazi, you can go ahead. You're ready.
Hello to everybody. I'm speaking from Iran, and I deeply appreciate Michigan University and Yale University for such a well-planned and well-executed conference. It's my pleasure to participate in the conference, and I'm happy to be here and share my presentation. The title of my presentation, could you see my PowerPoint? The title of my presentation, the study of how COVID-19 impacts on health in Iran. Introduction. In late 2019, an infectious disease was dropped in Wuhan, China, which the World Health Organization called COVID-19 or Corona. Can you hear me?
Yes, we can hear you.
Okay. Introduction. In late 2019, an infectious disease was reported in Wuhan, China, which the World Health Organization called COVID-19 or Corona. In 18 February 2020, 2 cases observed for the first time in Iran in Qom province, and on 19 February, the government of Iran confirmed that the COVID-19 virus has been observed in Iran. According to World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. World Health Organization defines mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. Undoubtedly, the outbreak of COVID-19 had serious consequences on the condition of health in Iran. In this article, I try to explore 2 aspects including mental health and social health. I've examined the impacts of corona on mental health of men, women, older people, and families in Iran. Uncertainty about the future, disruption to daily routine, business, and educational goals, reduction in physical activity due to university and school closures for children and students, and lack of interaction face-to-face with other people made problems for mental health in Iran. Social connections in Iran switched to WhatsApp and Skype. Students, teachers, and professors have virtual classes and meeting with Skype and Skyroom. Theoretical framework. According to Durkheim's point of view, there are 2 kinds of solidarity in societies: mechanical solidarity based on similarities, and organic solidarity based on differences. In traditional and primitive societies that are mechanically solidarity, all human beings engage in the same activities and have the same responsibilities. But in the modern and industrial societies that have organic solidarity, cohesion is based on the differences and distinctions of human beings, and everyone has different duties and responsibilities. Therefore, due to COVID-19 situation and less face-to-face connection in a traditional society with mechanical solidarity, people are really close together and don't have lots of mental difficulties. In a modern society with organic solidarity, people have less connection to each other and have lots of mental difficulties, like Iran, which needs others for its survival due to the division of labor and specialization of human efforts. And the rate of psychological problems in Iran had increased due to COVID-19 restrictions and social distance in the early stages of COVID-19, when people hadn't yet been vaccinated. Methodology.
So now we will have our second presenter because Ms. Farzaneh is not available right now. So we will go on with the next presentation. Our next presentation is by Ms. Mariam Salie. She's an MA in clinical psychology and community counseling. And her research interests are Muslim mental health in South Africa. So please give her a big round of applause to Ms. Mariam Salie.
Could I continue? Could I continue? The method of my research is the case study, and I use documents released by Iranian situation to conduct my research.
Assalamu alaikum wa rahmatullahi wa barakatuh. To those here in person and to those online. So my name is Mariam Salie. As you heard, I'm all the way from Cape Town in South Africa. I'm from Stellenbosch University. I'm a lecturer academic there, and I'm also a clinical psychologist in private practice. And this presentation is really a reflection. I'm currently busy with my PhD. So the presentation is in two parts. The first part is the reflection on my PhD work thus far. And then the second part is the reflection on a clinical psychologist, or rather a Muslim clinical psychologist in private practice during COVID times. I just also want to acknowledge my colleague Nuhaa Holland for her input in the presentation. Unfortunately, she's not able to attend in person, but she is with us online. So why a framework for Muslim mental health in South Africa? Globally, there's a drive towards developing treatment practices that are inclusive, that are culturally relevant, and sensitive to the specific needs and beliefs of different religious and cultural groups. And Muslims in South Africa, while they do share the religious framework with Muslims globally, I think the location, the culture, their sectarian views, and their race does influence their lived experiences. Understanding how South African Muslims conceptualize mental health will help the therapeutic process, will help motivation for therapy, maintenance of therapy, and accepting help from mental health professionals. So before we get into it, I want to give a little bit of a background on South Africa, or Muslims in South Africa. And so the first thing you need to understand is that Islam came to South Africa in 3 different streams. So at the moment, we make up about 2% of the population of South Africa. And the first stream arrived in 1658. They arrived as slaves, political exiles, laborers and soldiers from Indonesia, Malaysia, Bengal, the Malabar Coast, Madagascar, Java, and Bali. And among them was a political exile and prominent religious leader, Sheikh Yusuf, who began the spread of Islam in the Cape. Just a fun fact, I'm known as a Cape Malay because I'm from that, well, part of me is from that ancestry. And then 200 years later, a second stream of Muslims entered the northern and eastern areas of South Africa as merchants and traders, and these Muslims were predominantly from India. So you can see the first group of Muslims that arrived here, they arrived in the Cape, so Cape Town, and the second stream of Muslims settled in the KwaZulu-Natal area. And then the last stream of Muslims are migrants from other parts of Africa with significant Muslim majority populations, and they flocked to South Africa due to war, political turbulence, or failed economies in their origin country, or because of an interest in the democratic transition of South Africa. And again, while migrants also share religious beliefs with Muslims in South Africa, their culture, their history, their political experiences may differ. And Muslims' expression of Islam in South Africa is additionally influenced by their race and culture. And what I mean here when I talk about race is the imposed racial categories of Black, white, non-white, colored, African, Indian, and Asian, which are all socially constructed labels used during apartheid in South Africa. And I, of course, recognize that these categories purport meanings of social inequalities, but I just want you to understand the factors that influence how we shape our identity. So when you're thinking about how Muslims conceptualize the concept of mental health, one needs to keep all of this in mind. And then also, I'm not going to go too much in detail on this slide, but I really just want you to understand that South Africa has a long history of oppression and exclusion. So we were colonized. The first European contact was with the Dutch East India Company in 1652. Later on, the British. There's been wars, lots of exclusion of Black, and yeah, I use Black as an umbrella term. And then, of course, apartheid, which we have recently come out of, still a very young democracy from 1994. And we need to understand that during this oppressive history, Black people were considered other, ultimately disposable as a people. Their lived experiences, including their trauma and losses, silenced and perceived as meaningless. Black people experienced institutional brutality, lack of freedom and movement. And during apartheid, once again, Black people were faced with profound inequalities and denied basic needs, resources, and rights. And as I said, Black here is used as an umbrella term in reference to the historical categories of Black, Colored, Indian, Asian that I mentioned earlier. I think also important to understand is that South Africa is a low middle income country with lack of economic growth. Per capita income is below 3/4 of the world average. There's high probability of economic collapse, high rates of unemployment and poverty, and limited access to mental health care. Psychology in South Africa is considered for the elite, for the upper class. Historically, there was no access to the service for the previously disadvantaged. Currently, mental health care is accessible at primary and tertiary hospitals, but there are channels in order to access, there are waiting lists, and the amount of psychologists and psychiatrists in the public healthcare system is not enough to service the needs of the volume of people who actually need the service. And then with regards to private access, this is not affordable for many people. Only those who have medical aid or medical insurance will have access, but even then it is limited as medical insurance only covers certain conditions. So these factors are all important to keep in mind when I talk about the emerging themes later on. And while the themes appear to be associated with religion and culture, I think that the transgenerational identities, which is shaped by the history of oppression, colonialism and apartheid, perhaps also influences how South Africans and South African Muslims think about mental health and illness and psychology in general. So think survival mode, think trauma, because we were historically always told to just carry on. And this is some of the things that people said when I was interviewing them. So I'm using Arthur Kleinman's explanatory models because he speaks about the importance of understanding the patient's model or how they understand their illness. And he sees this as a very important part of the treatment process. As I mentioned, this is partly my PhD study, where I'm looking at explanatory models of mental health conditions amongst Muslims in the Western Cape. And I am interviewing 4 different stakeholder groups. So I've completed 2 groups thus far. I've done 20 individual interviews with Muslims who have used a mental health service. I've done 5 focus groups with 18 participants of the general Muslim public. And I intend to interview psychologists who treat Muslim clients or patients, and then also Islamic scholars. This is proving to be a little bit difficult to get, but inshallah I'll get there. So the emerging themes. The first one, which is maybe the most obvious one, is the whole concept of religiosity and mental health. Many participants shared the explanatory model that attributed mental health conditions to a lack of religiosity. So this included a lack or loss of iman, a lack of prayer, salah, and a lack of connection with Allah. And I must note here that individuals experiencing the mental health conditions do not necessarily subscribe to this view, but this is the view that they were brought up with, and they found it extremely difficult to get support because of this predominant view in the community. And then the supernatural world, the magic. So I've included some quotes there from some of the participants. And this explanatory model attributed to the supernatural world was interesting because there were some participants who believed in the supernatural world and attributed this to mental illness, and then there were some who didn't. And of course, the treatment for this attribution was ruqya, right? So it was treatment. The first thing, if you report to your family that you're having this experience, they would take you to an imam, and the imam needed to fix you. Interestingly, I've interviewed one Islamic scholar thus far, and he was saying to me that out of all the cases that they get where there is a thought that it might be gene-related, it's usually only 1 out of 10. He said it's actually very, very rare. And as with religiosity, incorrect explanatory models would lead to obviously lack of proper and suitable treatment for the mental health condition. And then I think this relates to the stigma associated with mental illness. So the other thing was madness, so that there was something wrong with you. So they used the word majnoon, and they used the word that is, it's a colloquial term, but it's used in the community where they say you're tati. Now, if they say you're tati, it means you're totally off your rocker. So separate to explanatory models that are associated with religion, this theme highlights the negative stigma and derogatory connotations attached to mental health conditions. Here, the individual is viewed as less than because of their mental illness. And also participants noted that growing up, whenever there was someone in the family who appeared to have a mental illness, or what we would perhaps understand today as a mental illness, they were distanced and seen as outcasts, and there was an element of fear. Then, family integrity affected or disgraced. So religiosity appears to be connected to this theme as a result of the belief that mental health conditions are caused by a lack of faith or connection to Allah. Mental health conditions are viewed as a disgrace, which affects the integrity of the family, and those diagnosed face shame and exclusion. Essentially, you are a bad Muslim, and that's why you are experiencing these mental issues. And so they are actually told not to talk to anyone about their condition, not to speak about it, not to make it known, because of it affects the family integrity. And then culture and mental health. Something that was quite prominent with the participants was they felt that culture and religion was enmeshed when we talk about mental health. Several participants highlighted the influence of culture on mental health experiences and how explanations are often given under the guise of Islam, but are actually culture infused. And in South Africa, race and culture is often something discussed together because they seem to have a bidirectional influence on each other. Different races have different cultures, which influences people's experiences and their responses to events. And then health-seeking behavior. There was a discrepancy with regards to religion and health-seeking behavior, with in some instances, participants believed that it was the Islamic duty, because of the verse in the Quran, to seek help from a knowledgeable expert if they were suffering from a mental health condition. But in other cases, participants were encouraged by family to seek help, treatment only from Allah, and were actually made to feel very guilty if they were seeking help from someone other than Allah. And posited this, so going on your musalla, doing your prayers, making dua, and asking Allah to grant you, to feel better from whatever's happening. And this was seen as this would be seeking help from an Islamic perspective. In some cases, it was about access also, as I mentioned. On the note of access, many participants reported that they did not return to therapy because it was a non-Muslim practitioner, and they felt like their religion and culture was not understood, and therefore they did not subscribe or feel comfortable with the treatment plans presented. There are very few Muslim psychologists in South Africa. In fact, psychology is actually a very competitive field, and it takes about 7 years for you to complete to be a practicing clinical psychologist. And there are very few Muslim psychologists, there are very few Black psychologists. And although transformation is high on the agenda in the field of psychology in South Africa, it's been a very, very slow process. So some observations: there was a reluctance to participate, despite the fact that I had these many interviews and lots of interest. Many people did not want to participate because it's not something that is spoken about in the Muslim community. There was also significantly more female than male participants. Out of the 20 individual interviews that I did, only 2 were male. And with the focus groups, there were 18 participants and 4 were males. One actually participated because he was doing a research study and wanted to get the experience of a focus group. I tried not to feel bad about that one. And the other 3 were actually encouraged by other female participants. So really, only the 2 in the individual interviews, participated willingly. So out of what I've done thus far, it's very clear from the participants that psychoeducation is needed. Clear indication that this is what the Muslim community wants. And while there has been shifts, it has been very small and very few because it's still highly stigmatized and not spoken about. In fact, in the talks that I've been listening to yesterday at the conference, there's so much that I can relate to because there's so much that we share. The stigma that this doesn't apply to us, there's no mental illness in Islam. And I actually had one participant who said, if our perception is that mental illness does not exist in the Muslim community, this means that we will never get to address it. So when I completed my studies and I started practicing, the first thing I did was I looked for other Muslim psychologists and started a WhatsApp group, mainly for referral purposes. And everything starts with a WhatsApp group. And so we are actually now trying to formalize a network of Muslim psychologists in South Africa. One of the catalysts, I would say, for an increase in the talks of mental health recently was there was 3 suicides in Cape Town. This is during COVID times, and there were 2 of them were young boys, and one was a young mother. And this started the debate. There's always a catalyst for talking about mental health. There's a talk about it, and it dies down. And so again, there was this this debate. But very sadly, the debate was around the Janaza Salah of those 3 who completed suicide. And the debate is whether we can perform Janaza Salah, on them or not. So there are these questions, there are these debates, but at least they are talking about it. With COVID, there was a visible increase in interest in mental health. There were requests for interviews from the Muslim radio stations in Cape Town, from organizations to present workshops on mental health and well-being, mental health and COVID, depression and suicide, dealing with anxiety. So I'm positive because this shows that there is an interest. And then I've been in private practice since 2018. I've always had a steady stream of Muslim clients. So this shows that there's a need for it because when people seek me out, they seek me out because I'm Muslim, or they seek me out because I'm colored, right? So in my community, I'm considered colored. The political term for us is black in South Africa, but under that category, there's black and colored and Indian, so I'm considered colored. And we've recently, myself and some other Muslim psychologists have started working on formalizing a Muslim psychological network to provide a directory for Muslim practitioners because people don't know where to find us. And then also to set up a network that could provide psychoeducation, create awareness, and hopefully, inshallah, do some research in this area because it's a under-researched area in South Africa. So I have 2 referring doctors, and in my area, there's about probably almost 30 GPs in my area. But I haven't advertised myself to them simply because I cannot keep up with referrals. So like I said, they request to see me because I'm Muslim or because I'm colored. And in both instances, they want someone who can understand their world. I had clients who said to me, I'm coming to you because I don't have time to explain. So I just want someone who's going to understand me and be able to help me. So, but as I mentioned, transformation is slow. There are very few of us. My colleagues, we are always full. There's always a waiting list. But inshallah, we're trying to increase that network. Thoughts on the way forward, and I would really appreciate your input on this. Of course, because I'm an academic, more research in Muslim mental health in South Africa. Developing a framework for non-Muslim practitioners working with Muslim clients, because this was something that stood out in my interviews with participants, that many of them access service from a non-Muslim mental health practitioner, and many of them did not return because they felt firstly like they're not understood. They felt that the advice was not given, or the advice given was not something they could subscribe to because it maybe it wasn't in accordance with their values. And so I thought we really need to, because there's a few of us, and while we're waiting for more Muslims to qualify, to at least develop a framework that non-Muslim practitioners can use when working with Muslim clients. Then also developing a directory of religious leaders for collaboration, mental health campaigning and education, because to address the stigmatization of mental health, to formalize a Muslim psychological network, community-based interventions and collaboration with religious leaders. That's it from my side, just acknowledging the bibliography there. Shukran so much. Made it in time.
Give another round of applause, please.
Okay, we'll try again with Dr. Ejazi. Dr. Ejazi, can you hear me?
I can't hear you. Can you hear me? Can you hear me?
Can you hear me?
Yes.
Can you hear me?
Interesting.
Can you hear me?
The speakers? Hang on. So she says, I'll move my headphones. We can hear you. We can hear. Okay. Dr. Ejazi,
Can we-
try again. Hang on.
Can you hear me? Can you hear? Okay. Okay. Can you hear me? Could I start? Could I start? Okay. Study of how COVID-19 impacts on health in Iran.
No, I think we're good now. All right. Sorry about that. I'm going to share you want
The
to?
study of how COVID-19 impacts on health in Iran. Could you hear me?
Yeah, we can hear you now. We can hear you.
Oh, you can hear. Okay, I get it.
Would you like me to share it or do you want to just screen share your presentation?
I want to share.
Okay, you can share it then. I made you co-host, so. Okay.
Can you see it?
Yep, we can see it.
The title, okay. Hello to everybody. I deeply appreciate Michigan University and Yale University for such a well-planned and well-executed conference. It's my pleasure to participate in the conference. The title of my article, The Study of How COVID-19 Impacts on Health in Iran. In late 2019, an infectious disease was reported in Wuhan, China. World Health Organization called COVID-19 or Borna. In 18 February 2020, 2 cases observed for the first time in Iran in province, and on 19 February, the government of Iran confirmed that the COVID-19 virus has been observed in Iran. Okay. I can't see my PowerPoint. Please wait.
No, take your time. It's okay. We can see it on our. So.
I can't see my PowerPoint completely.
Can't see your PowerPoint.
because some names are here.
Okay. Do you want us to, is it different from the one you emailed us? We can just use that instead. You can just tell us to press slides. Second. Check.
Because when I share, the names are here and I can't see my PowerPoints completely.
Okay.
Could I remove my share?
Yeah, go ahead. Go ahead. You can remove your share.
How could I do it?
That's okay. It happens. Again, this is a hybrid conference, so we're trying to adjust with both in-person and Zoom. So it's okay. Don't worry about it.
How do I remove it?
So you should see the green on top. You can just remove. It would say like you're viewing or like you are screen sharing if you move your cursor up. You'll see like a green line.
Oh yeah, I can see your line.
And then you'll see a red thing saying stop screen share.
Yeah.
Perfect. Okay, so I'll put you on the Google one so we have your slides because I want you to present no matter what you're going to present.
Okay. Can I go on?
Yeah, of course. Do you see the presentation now?
Okay. According to World Health Organization, health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. World Health Organization defines mental health as a state of well-being in which an individual realizes his or her own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to his or her community. Undoubtedly, the outbreak of COVID-19 had serious consequences on the condition of health in Iran. In this article, I try to explore two aspects, including mental health and social health. I've examined the impacts of corona on mental health of men, women, older people, and families in Iran. Uncertainty about the future, disruption to daily routine, business and educational goals, reduction in physical activity due to university and school closures for children and students, and lack of interaction face-to-face with other people make problems for mental health in Iran. Social connections in Iran switched to WhatsApp and Skype. Students, teachers, and professors have virtual classes and meeting with the Skype and Skyroom. Theoretical framework. According to Durkheim's point of view, there are two kinds of solidarity in societies: mechanical solidarity based on similarities and organic solidarity based on differences. In traditional and primitive society that are mechanically solidarity, all human beings engage in the same activities and have the same responsibilities. But in modern and industrial societies that have organic solidarity, cohesion is based on the differences and distinctions of human beings, and everyone has different duties and responsibilities. Therefore, due to COVID-19 situation and less face-to-face connection in traditional society with mechanical solidarity, people are really close together and don't have lots of mental difficulties. In a modern society with organic solidarity, people have less connection to each other and have lots of mental difficulties. Like Iran, which needs others for its survival due to the division of labor and specialization of human efforts. And the rate of psychological problems in Iran had increased due to COVID-19 restrictions and social distance in the early stages of COVID-19 when people hadn't yet been vaccinated. The method of my research is the case study, and I use documents released by Iranian institutions to conduct my research. About findings show virtual connection will have a terrible effect on elderly people and adults, and they cannot adapt to them so easily. Virtual connection increases the depression among communities and has negative effects on individuals. As a result, appointments with the psychologists are going to increase in Iran. The virus has increased The dropout rates including 210,000 primary school and drops 760,000 high school. The demand for counseling has been tripled and domestic violence has been grown by 77%. According to the existing evidences in the last 2 years, due to the corona, people have suffered a lot of financial and human losses, as well as depression, anxiety, double pressure, and stress. Out of 10 women reported violence against themselves, indicating an increase in domestic violence. The number of fights leading to beatings has increased by 10%. Due to the spread of COVID-19 in the world, Iran's economic condition is going to get worse, and consequently men tolerated economic hardship of life due to the loss of their job. Conclusion. We are in the middle of the COVID-19 pandemic and are not able to predict exactly what happens next. However, we could create practical solutions. Nowadays, special online classes and health, physical, mental, and psychological issues should be held in girls' and boys' schools. Education has extreme effect on social and mental health. Mobile health app is a great tool for send medical messages. Governments in Iran should create effective solutions by using communication technologies such as Zoom, MS Teams to obtain knowledge and skills, and to ensure health of Iranian people during COVID-19. According to some Iranian psychologists, the goal of mental health is to achieve inner peace and satisfaction. In Islam, they assert there are teachings for achieving peace of mind and such as remembering God, trusting in God, and patience to treat the mental illness caused by the spread of virus. Thank you so much for listening.
Give a round of applause, everybody.
Thank you so much.
Sorry about
Thank you
technical.
so much. I'm so sorry for what happened.
Told you we were going to present. All right, fantastic. Okay. Yep. So we're going to have our next presentation up shortly. But thank you so much.
Thank you so much.
Thank you so much, Ms. Farzaneh Ejazi. Now we have our next presenter. So we have Ms. Farwa Aslam and Ms. Uzma Ilyas. Ms. Farwa Aslam is an MS scholar at University of Central Punjab, Lahore, Pakistan. Please give a big round of applause to Ms. Farwa Aslam.
Thank you so much for inviting us.
It's our pleasure. Are you going to screen share? Do you want us to do the same thing? And we have your slides here. We can just project it here. And I'll just click the slides.
Okay.
Okay, we'll do that. Just give me a couple of seconds.
Can you see my screen now?
We're screen sharing the slides now. Do you see it?
Can you see?
On your end, no, but we have it screen shared, so we have your slides up.
Okay, so I recently shared my screen. Can you see this?
Hang on. Let me stop. Okay, you go ahead. You share your screen.
Okay, thank you. Okay, my name is Farwa Aslam, and I am presenting my abstract titles: Light Triads, Fear of COVID-19, Nosophobia, Health Anxiety, and Interoceptions among Pakistani medical officers. And my co-presenter is Ms. Uzma Ilyas, Senior Lecturer at the Department of Psychology, University of Central Punjab. So as COVID is a global pandemic and has become a major public health burden worldwide, and current health system in underdeveloping countries affecting a lot all of us. During this COVID-19, medical officers' attitudes and the behavior demand the humanistic statements and actions, and the stress and threats to their life can generate the psychological as well as physical concerns. There are psychological concerns, including the fears and anxiety, and nowadays they are under direct contact with the COVID-19 because they are treating the patients, they are contracting the diseases, and they are treating the people with the virus. The physical exertion and anxieties leads to increased risk of mental health issues among medical officers, and the incidence of fear of contracting the illness is much higher among the Middle Eastern countries because of the underdeveloped system, because of the lack of the facilities, because of the lack of the equipments, including the COVID-19 kit. So the study variable largely based on the my light triads, and according to general perception, attributes that are mostly highlighted among the people of medical profession are the love of humanity and the human dignity. They value the human dignity. They serve them despite of their personal commitments and concerns, and such traits like care for others are come under the domain of the light triads. And the light triads are basically the consist of 3 personality traits. One is the psychiatrism, treating the people end to end, mean to an end; humanism, believing in the dignity of the human being; and the faith in mankind, believing in the basic humanity and the humanism. Fear is basically an emotion that arises as the result of threatening situation, and the fear of COVID-19 is the fear of contracting the virus and transferring the virus from one person to another person. And according to WHO, coronavirus is the communicable disease and can easily transfer from one affected person to another within a few minutes of infection. Under such stressful circumstances, the health-related concerns can arise in any person, whether he or she is from medical profession or not. And these concerns prevail among the medical community is common. And those concerns generally diminish their decision-making ability. And the perception and the concern of having the illness is coined by the term which is called nosophobia. And the nosophobia is the perception and distrust of getting or acquiring the serious illness without actual stimuli regarding the presence of illness. This term is mostly observed among the medical officers and the medical students because of the fact they have in-depth knowledge, they have in-depth understanding of diseases because they treat the people with the diseases and they study them well. The fear of developing such illnesses proceed to a condition characterized by the preoccupation with getting or acquiring a serious medical condition, which is called the health anxiety, and that concept is also explained in the DSM-5. Living in a fear of or in constant sickness, even through unauthentic medical tests, is a somatic symptom disorder or is a health anxiety disorder. And according to DSM-5, there are 4 distinct features. First one is the worry or the fear of serious illness. Second one is the duration must be of more than 6 months. Third one is the reassurance seeking, and last one is the interference with the daily life functioning. When there is the risk of the concern about having the serious illnesses, there must be concern about the internal body mechanism. And the irrational concern arises due to such situations and such symptoms. And to note these situations and bodily signs and symptoms is coined by the term interoception, which is the insight of inferred information that arises from one body. what the person feels like in our body, what the person is going through, and what is the internal mechanism. So in a Pakistani collectivistic culture, the belief of the patient or the patient's family is entirely on the lifesavers or the doctors, without understanding their concerns. And after taking, medical professionals are bound to look after their patients in every situation. They're fighting as a frontline warriors to save the people from the COVID-19 attacks and directly experiencing the threats. So basically, the purpose of the study is to understand their personality traits, the positive personality traits, the nosophobia, their health concerns, their health anxieties, their perception about the illnesses, and the interoception, what they're feeling about their body during that COVID-19 stress. Because everyone was concerned about their own health. Nobody was getting into the doctor's perception. Nobody was going through that condition, what they are feeling. So the previous literature and the findings suggests that there's a moderating relationship between the physical concern associated with health anxiety and the fear of contracting COVID-19. The 2019 research was conducted, and the same results. So the physician visit and of 6 months, more than 6 months, and having this health anxiety disorder because they were concerned about their illnesses. Nosophobia and the degree of medical knowledge was also investigated among the medical students through a descriptive cross-sectional study, and the result evident that there only the 43% of the medical students know about the fear of catching diseases, which is called the nosophobia. Because they understand diseases well, and they got this perception because they are having these illnesses, and in a very stressful situation. 22.8% admitted the fact that they are using the psychotic drugs both to relax and to sleep. So the medical students are more vulnerable to population to such a condition, which is called nosophobia. So for the current study, a methodology was used, and the study design was correlational cross-sectional research design. A non-probability purposive sampling technique was used on a sample of 300 medical officers from the 3 domains of medicines, MBBS, BDS, and DPT. Data was collected manually from the respondent after taking the consent during the heightened wave of COVID-19 by following all SOPs imposed by the government. Data was collected through Google Form as well, and during the heightened wave of COVID-19, and initially the data was of 415 medical professionals, and after removing the responses that were incomplete and did not meet the research criteria, a total of 300 samples were included for the further analysis. Statistical analysis was done by using the software SPSS, Statistical Package of Social Sciences, Vision 22. Pearson product movement correlation was used to investigate the relationship between targeted variables. The assessment measures for investigating the variables were light triad scale, fear of COVID-19 scale, medical student disease and perception scale, short health anxiety inventory, and multi-dimensional assessment of interoceptive awareness scale. Certainly for conducting a research, we have the inclusion as well as inclusion criteria to cut off and to define the research strategies. Inclusion, all the medical officers who were doing their house duties were included. The medical officers from the 3 above mentioned domains were included: the Bachelor of Medicine, Bachelor of Surgery, Bachelor of Dental Surgery, and the Bachelor of Physiotherapy. Medical officers who were in daily interaction with the patients for performing their duty were included, and medical professionals from the government, semi-government, and the private hospitals were included, and the medical officers with middle and upper middle socioeconomic status were included. In the inclusion criteria, we excluded those medical professionals who are not doing their house duties, who are other than 3 domains of medicines, MBBS, PDS, and DPT, who were currently on the break due to COVID-19, and medical officers who had another job except the house job and who had maximum work experience were excluded from the research. So the finding of the research indicated that there was a significant and positive correlation between the light triads, fear of COVID-19, and nosophobia, health anxiety, whereas the light triads is negatively correlated with interoception. The previous literature suggested that the people with high interoception sensitivity and more altruistic behavior, and the study was conducted on these variables as well, but the improving interoception does not increase the altruism. Specifically, the individual with health anxiety compared with the healthy participant exhibit high significant interoceptive awareness, and the high physiological awareness and the health anxiety were prevailing among the medical officers who were engaging in altruistic behaviors during the COVID-19. So the limitations of the study, the research could only investigate the quantitative aspect of the selected variables. It could be qualitative as well. Many students who were willing to participate in the study, who were not willing to participate in the study because of the lengthy questionnaires. The study was conducted during the COVID-19 situation that was challenging for the researcher, and only 3 domains were included. So the findings supported that the light triads perception and distrust of contracting the disease based on unauthentic medical doubts and bodily awareness were associated during COVID-19, and the light personality traits are found to be associated with anxiousness regarding health and low comprehension of body internal mechanisms during current pandemic. This study will help in finding the true correlations and the health-related concerns in interpretation and true interpretation of the bodily concerns that are found among the medical officers, and will also address the providing the psychological first aid for the medical community as well, because they are serving during the current pandemic regardless of their distress and the lack of resources, because their mental health is very important for the mental health of patients. Thank you so much. Thank you for your time and attention.
Thank you so much. That was a lovely presentation. Appreciate it.
Thank you so much, Ms. Farwa, for the wonderful presentation. And now we have our next presenters. So our next presenters are Dr. Nazmim Borna Bhuiya, Dr. Farha Abbasi, and Mr. Alamah. Nazmim Bhuiya is a researcher and program evaluator at the Massachusetts Department of Public Health, and she holds a PhD from Harvard T.H. School of Public Health. Dr. Farha Abbasi is the assistant professor in the Department of Psychiatry at Michigan State University and is the founding director of Muslim Mental Health Conference.
Thank you. First of all, great job, guys. It's not easy to do this internationally, globally, and keeping it hybrid. So I'm really proud of these two presenters. Adam, you didn't send your bio, but let me introduce Adam. Alamah is one of my medical students that I mentored and has spearheaded this study. So we kept the questionnaire very open-ended because I just wanted to capture how is COVID-19 impacting Muslims in academic settings. So that age group, I wanted to focus on that. And we kept questions very open-ended. We did talk about mental health. We did talk about spirituality and how religion or spirituality is part of the coping skill, family, connections, friendships, how all that impacts college going academic setting situation. Because we all know COVID-19 created a lot of education uncertainty, academic uncertainty. So with that, I will pass this on to you both. So just keep it here.
Are you able to see my screen?
Yep, we can see it.
Okay. Okay, wonderful. Assalamu alaikum. I'm Nazmim.
Assalamu alaikum, everybody. My name is Adam, and this is our presentation. It's called Affective Experiences of COVID on Emerging Adults Living in the USA, an Exploratory Study. So a little bit of an overview. We're just going to discuss the purpose, get into the methodology, talk about some findings, and then get into some key takeaways. The purpose of our study is just to understand how the pandemic affected the mental health of emerging adult Muslims living in America. In terms of the methodology, we had a 51 question survey questionnaire, 40 questions being closed-ended and 11 being open-ended questions. And they were organized by theme, starting with the impact of the pandemic, then going into spirituality and religiosity, and then finally touching on some social support. So in terms of the approach, we started our data collection on the first day of Ramadan last year, April 12th. We distributed it electronically due to the nature of the pandemic to university, Muslim student associations, local masajid, and social media. In terms of exclusion criteria, we excluded anyone who was diagnosed previously with anxiety or depression, and we focused on the age group of 18 to 30 years. We had 61 eligible participants, and we had both quantitative and qualitative analysis. In terms of participants, we had a rough split between male and female. We had the majority of our participants with a bachelor's degree, and the majority of our participants were single. And in terms of race and ethnicity, 57% of participants were South Asian, followed by 28%, which were Middle Eastern, and then African-American 9%, and then a few others.
So we'll delve a little bit into our findings, which we've organized by categories. So we looked at psychosocial and economic impact. I apologize, it keeps, I have no idea why it's advancing the slides without, okay, so I will hit pause. So overall, a majority of the participants were socially and emotionally impacted by the pandemic. And looking across the individual responses, we found that more than half the participants were impacted 2 or more ways by the pandemic. And then in terms of job loss or being able to start the school for full time, this did not seem to be an issue for the respondents. And regarding family diagnosis, it was like an even split of family members being diagnosed with COVID-19 and another almost a little over 50% not having a family member diagnosed with COVID. And then in terms of depression and anxiety, a majority of the participants, over 80%, did indicate that they felt depressed or anxious during the pandemic. But interestingly, less than 25% actually sought therapy. But those who did seek therapy did find it helpful. We also found that over 70% of the participants felt down due to the pandemic. And we had also looked to see if there were any gender differences, though there weren't anything significant. We did find that there was a larger proportion of females that experienced or that felt down compared to the male respondents. Most of the participants experienced loneliness, social anxiety, or having difficulty communicating with others. And almost half of the participants indicated that their mood worsened since the pandemic started. So for the participants that indicated that their mood had worsened or stayed the same, we had asked them an open response question on asking them how the pandemic stress impacted them. And so The responses were sort of categorized into 4 themes. So these were the 4 themes that emerged from the data. And so some of these responses actually quite align with some of the findings that we shared earlier. In that more respondents did discuss the emotional and social impact, and about 1/5 of the participants discussed how it impacted their daily function and productivity level. And there was one participant that said that it didn't have any impact at all. And so some quotes that helped capture these themes. One participant said, "I felt happy, no stress, more family time, and more time to reflect on myself." And then this quote captures both the emotional and social impact: experience loss of friendships, connections, ability to travel, move around, constantly worrying about germs, concerns about family impact loss increased. I'm so socially awkward now, whereas I used to be more outgoing. And then another participant said, disjointed and detached from the world. And then another quote, I feel I have become more lazy and less productive on top of being impatient. Are you on mute, Adam?
Sorry. Yeah, so now we'll discuss impact on behaviors. So not surprisingly, 68% of participants stated that their social media use increased during the pandemic. There was no real difference between drug use before or after the pandemic. However, among individuals using a substance, slightly over half stated that their use increased during the pandemic, 57%. As we can see here, the pandemic really did impact diet, weight, and sleep. 70% of participants stated that the pandemic changed their diet in some way, shape, or form. 74% stated they actually gained weight during the pandemic. And 71% stated that the pandemic impacted their sleep. And it's not shown on this slide, but one of the qualitative questions that we asked, how did the pandemic impact your sleep? One of the big themes that we saw was participants saying that it impacted the time at which they would fall asleep and the time when they would wake up. And so keeping in mind the literature on circadian rhythms, I think it's very, very important. And it's a crucial finding. Physical activity, the majority of participants stated that they were engaging in physical activity, and that half of them stated that the closing of gyms during the pandemic didn't really impact their mental health. So they found a way to be flexible and to adapt and keep, the physical activity. In terms of religiosity and spirituality, we had a number of questions looking at this. The majority of participants stated that they were actually practicing extra prayer or meditation during the pandemic, 70%. Slightly over half stated that they were reading more Quran, and in general, 61% stated that their faith was impacted by the pandemic. And over here, we have 2 different questions. So one question we asked, has your faith increased, decreased, or stayed the same during the pandemic? 50% stated that they actually felt that their faith increased during the pandemic. And when we asked another qualitative question, just, can you tell us a little bit more? There were some really cool themes. Some of them being feeling a greater connection with Allah subhanahu wa ta'ala, greater connection with family, and just a feeling of tranquility, peace, and relaxation. 29% stated that their faith, stayed the same. And, they highlighted things such as just feeling like a lack of energy, one good day and one bad day, fluctuating. And what was really interesting was that they had a desire to increase. And then 21% stated they actually felt their faith decrease during the pandemic. And some themes included, just feeling more isolation, less social interaction, feeling disconnected from the community, and less motivation to practice. So we get into some quotes here. One person said, been lazy with my prayers, trying to improve because I feel guilty. And another person said, since I'm a convert, I'm the only Muslim in my family and previously depended solely on my community. After I had to depend on myself, and that doesn't work as well. So here we can see the importance of, the social aspect of going to a masjid in person, which wasn't available during the pandemic. One person said, I feel that I get some calm or relief from the spiritual activities, but I don't feel I have enough energy to increase my spiritual activities. Another person said, pandemic made me feel more connected to God while working on myself, which felt great. And last but not least, one person did say, in this crucial time, spiritual strength has undoubtedly increased when you have more time to spend praying at home. It makes me feel elated and peaceful for the soul. So really interesting mixture of experiences here, but I would say that the majority of participants felt that their faith either increased or stayed the same during the pandemic.
So we had also looked at what resources participants had access to and also about their coping mechanisms. And so in terms of social support, overwhelmingly, most of the participants did say that they had family and or friends as part of their social support system. And then again, looking at responses across individuals, we found that most participants have at least like 2 or more types of social support sources. We had also asked participants to indicate on a scale of 0 to 10, 0 being extremely low social support and 10 being extremely high social support, like to indicate their level of social support that they had before and after the pandemic. And so as you can see on the left side, before the pandemic, participants seem to have a higher level of social support than after the pandemic, as it was spread a little bit more distributed across the scale. And also there was a slight decrease in the mean, where before the pandemic, it was about 7.3, whereas after the pandemic, it was about 6.2. So there was a slight shift. And then we looked at individual responses, and about a third of the participants said that their social support level increased, while there was another third that stayed the same, and another third indicated that their social support decreased during the pandemic. And then we asked how participants, how effectively they could deal with stress. Again, on a 0 to 10 scale, 0 being least effective and 10 being most effective. And as you can see in this graph, more participants indicated that they have effective ways to deal with stress. And so this slide over here is a representation of, it's a word cloud essentially of the responses. And so we asked participants how they were dealing with stress during the pandemic and how it compared to how they dealt with it before the pandemic started. And as you can see there, it wasn't a whole lot of shift. So we categorized how they were dealing with stress, and both before and during the pandemic, more participants did use emotion and behavior focused coping, followed by social focused coping. Participants did share that during the pandemic that there were changes and activities, both in positive ways and negative ways. And positively, people were spending more time outdoors, spending time with family, and on hobbies such as cooking. And then in terms of like negative ways, they were eating and sleeping more. So this was very interesting, I thought. More participants indicated that, well, it was over 70% participants indicated that they or their family had access to mental health resources. And we had asked participants to report on a scale of 0 to 10, 0 being least likely and 10 being more likely or to seek treatment if diagnosed with depression. And as you can see on the graph on the right side, that there were more participants who are likely to seek treatment if they are diagnosed with depression or anxiety, and the mean score was about 7. So some key takeaways, and so our findings do show that most of the participants were impacted by the pandemic, both positive and negative ways. Many of the participants did feel depression or experience anxiety, feeling down, but they didn't seek therapy. So there may be some level of resistance or reluctance as to why they didn't seek therapy. And this could be associated with stigma or cultural barriers, but this was something we didn't assess. But however, it also could be that they didn't seek therapy because they had protective factors, as our findings did show that many of the participants did have access to a social support system and did feel that they were effectively able to deal with stress. And also, many did indicate that they did increase their religious or spiritual practices, which may have helped provide solace during the pandemic. So there were some limitations to this study. There's self-selection bias, as participants could choose whether to participate or not. And generalizability in terms of, we did have a small sample size, and also it may not reflect the perceptions or the experiences of all young Muslims living in the US in the academic settings. So some areas to further explore. I mean, this study really helped provided a foundation for deeper exploration. It would be interesting to delve into accessing mental health and support resources, and what may be some barriers to accessing those resources. And this could help us understand how we could create awareness in terms of facilitating access to care and treatment. And it would also be interesting to see how the experiences are now that we're a couple of years into the pandemic, supposedly in the post-pandemic era now. And so it would be interesting to see what the impact looks now. And as we have looked specifically at the 18 to 30 age group, it would also be interesting to see how the impact looks across the different generations. We would like to acknowledge 3 individuals, Salman Perez, Alina Aga, and Hawa Abbas, for all their work in developing the survey and helping to distribute the survey. And lastly, thank you very much. We appreciate your time. Thank you.
Before we open up for questions, one piece I wanted to add was that when you look at the mental health access part of it, so there is more. When I started working in the community, there were 3 aspects that I was focused on. One thing was creating awareness around mental illnesses. What is mental health versus mental illness? Acceptance that Muslims can get impacted as well. When we say 1 in 4, that includes Muslims as well. And then came the creating that access, culturally appropriate access. So what I see now is that there might be more awareness about mental illnesses, but I still see that not that many are seeking care. So there is this hidden stigma still that so on surface, when you talk to them, they are like, yes, we know what depression is, what anxiety is. Yes, we are willing, but how many do access care is still a big barrier that we still have to explore. So those that did explore, did access therapy, did benefited from it, but unfortunately, that's still a very small number. And that's the area we are going to focus on going further. So thank you. Thank you both. Amazing job.
I want to thank all of our presenters for their wonderful presentations. We'll give them another round of applause. That we have live, you can come to the stage in case there are questions for you, Mr. Mariam and Dr. Abbasi. And then for those of you who are virtual, please stay around because we will likely have questions for you. We do have a couple of questions that came in virtually. For those of you who are in person, there are cards. If you would like to ask a question, you can just raise your hand and a card will come to you. And for those of you who are virtual but haven't sent any questions in the chat, please go ahead and ask your questions there and we will address them as they come in. So the questions that we have from the chat, I'll go through those first. Both came for our last set of presenters. And I know that you all, some of you are virtual and some of you are in person, so you can decide who will. Okay. All right, so this question was the family with COVID-19 a factor, even if they are not dependent? So no caregiver burden. So no, I need to provide further clarification. Was the family with COVID a factor, even if they did not provide, even if they were not a dependent? So no caregiver burden.
I would, a factor in what? I don't understand the question.
Let me
Dr.
answer.
Abbasi will.
Okay.
So I guess what the question is about is that how having families impacted by COVID-19 contributed to their depression, anxiety, or their impact of COVID. And of course, we had I can just assume by collaborating with other research projects that played a very important part. That one thing was the fear that how COVID-19 is going to impact me, but the biggest fear was losing loved ones to COVID-19. So if so many, almost, what percentage had family impacted? Almost 50%, right?
Almost 50%.
Almost 50%. So if you had that high number of family getting impacted by COVID-19 or being sick, I am 100%, we didn't explore that question, but I'm very sure that by using other research projects that was a major factor contributing to all of our anxiety, that what if we lose a loved one to COVID-19? So
yeah, so our qualitative response, so we had that question in terms of the pandemic stress and how it's impacted you. And so some participants did express the fear of losing family members. So that was something that participants did share.
All right, and we have another question for our last group, and I also recognize we're short in time, so we'll ask maybe one other question. Were the mood symptoms subjectively reported, or did you use tools like the PHQ-9?
So we did not use PHQ-9. I think it was more subjective. The thing is that we had to take in consideration how much time, we had to keep the questionnaire so that we keep them engaged. We don't lose them. So we had to keep it already the questionnaire, the questions were so many that we had to, but that's the idea is that if we follow up on the study, that we can explore those areas more in detail.
Thank you. So this last question is for our first presenter. Could you discuss a little bit more about how imams in South Africa look at mental health? Do you foresee having any imams as allies in forming a Muslim mental health program? Also, is there government funding for this work in South Africa? And I can give it to you.
That's a very good question. At the moment, there is not much collaboration between imams and mental health professionals. It's something I'm working on. One of the imams that I have interviewed, and I also find that there's a different approach to mental health, or understanding at least, between the younger imams and the older imams. When I speak to younger imams, they are much more familiar with psychology, or much more psychologized, and understand mental health differently. And so when they presented khutbahs, like when there were these suicides, they were able to present it in a way that was true to, you know, a balanced understanding of mental health. Whereas you find those older imams that still have misunderstanding or misperceptions about mental health and illness. So at the moment, there are no collaborations that I'm aware of. It's something that I would like to work on as part of my PhD work, because I am interviewing imams, and I would like to, I don't know, work on something with them where we can collaborate to create that understanding, firstly amongst the imams, because I know there is imam training programs, and so the idea is that, inshallah, I can collaborate with them to include mental health training or mental health first aid as part of the imam training. So I think there is potential for that. As far as government funding, there's government funding for social impact work. Even within the institution that I'm at, there's social impact grants. So these are probably two funding areas that one could look at to help fund this kind of work. Okay.
So we are going to wrap it up. Unfortunately, we don't have too much time for more questions, but as I've said in other sessions, if you have questions for the presenters, please engage with them in the app. The app is a really great place to connect and meet new people, and I'm sure our presenters will welcome any questions or comments that you have about their work. We will wrap up the session now. There is going to be another session in the same room if you're in person, and also the same virtual space if you're virtual in 15 minutes. Assalamu alaikum. Thank you all for your questions and your participation. And thank you to our presenters.